Starting, all attendees are in listen-only mode.
Hi, good afternoon. Today is February 26th. I'm Donna Will, Professional Development Coordinator for the Developmental Disabilities Administration. We're welcoming you today to the DDA Amendment number 3, 2020, Guidance Memos and Webinar. Our presenter for today is Rhonda Workman, Director of Federal Programs, and also Patricia Stokey, Director of Programs, who will be helping facilitate questions. Before we begin, I'd like to go over a few things about the webinar. All participants are in listen-only mode. We had about 1,300 people register for the webinar today, and at this moment we have about 700 people on. And just in case people get locked out, it locks out at 1,000 people. We are recording the webinar today. There's two options to listen to the webinar, and that's by computer and phone. And if you notice on the right in the panel in the audio section, you can switch if you have trouble hearing. We have one handout for this webinar, which is in the handout section on the panel to the right. And you can email me if you want a handout and didn't get one because you're on the phone. Questions can be typed in the question or chat box in the webinar panel, and we will get to those periodically throughout the presentation. So now I'm going to introduce Rhonda Workman. Good afternoon.
Thank you, Donna, and welcome everybody to today's webinar. Next slide, please. Donna, if you can go to the next slide.
Give me a second.
Okay, thank you. As Donna's going to the next slide, on behalf of the DDA, we want to welcome you to today's webinar, which is focused on shared guidance memos related to the Family Supports Waiver, Community Supports Waiver, and DDA's Community Pathways Waiver. These are all specific to Waiver Amendment number 3 that was approved by the Center for Medicare and Medicaid Services on January 19th, 2021. Each memo notes specific stakeholders for which the information applies, such as participants, coordinators of community services, providers, and DDA staff. This webinar will provide an overview and information directly from our 8 program-related specific memos. After each memo, we will respond to a few questions related to that memo before moving to the next memo. As we have today, we may not be able to address all of your questions. Frequently asked questions not already addressed in our memos will be created and posted to the Amendment number 3 dedicated guidance memo page. Across all DDA regions, the DDA is here to support participants and family members' questions and our coordinators of community services and providers as they implement these enhancements. Next slide, please. Recently, the DDA has updated and posted the Amendment number 3 guidance memos on the DDA webpage. To access and view this information from the DDA homepage, which is reflected here on the left of this slide, you click on the What's New at DDA link from the left navigation panel. You'll note the red arrow that's demonstrating it. This will bring you to the latest DDA updates dedicated page that includes a link to the DDA Amendment number 3 guidance and memo dedicated page, as reflected on the right side of the slide. Next slide, please. When you click on that, it will take you to that dedicated Amendment number 3 guidance memo page, which includes the 8 program-related memos and links to the Family Supports, Community Supports, and Community Pathways dedicated Amendment number 3 pages that includes the approved waiver from the Center for Medicare and Medicaid Services, in addition to the track change documents and other information that we have shared. Next slide, please. Please note that the guidance memos are intended to highlight the changes in the DDA waiver program created by Amendment number 3. Guidance memos do not address all applicable DDA waiver program requirements. To review all applicable DDA waiver program requirements, please refer directly to the Amendment number 3 of the DDA waiver program application that was effective January 19th. As applicable, the DDA Appendix K, Emergency Preparedness and Response, may supersede this guidance, standards, and requirements while the Appendix K is in effect. Next slide, please. Next slide, please. Memo 1 relates to waiver eligibility guidance, specifically changes in eligibility criteria for the 3 DDA waiver programs. To be eligible for participation in a DDA waiver program, the applicant must meet all applicable criteria for technical, medical, and financial eligibility criteria. For Amendment number 3, it changed some of the technical eligibility so that the DDA waiver program will now support a specific age or residential service need. Please note, all current participants, regardless of age or services they're currently receiving, will remain in their current waiver program. The new eligibility criteria will only apply to new applicants as of the January 19th date. Next slide, please. As noted in the guidance, each of the DDA waiver programs will support specific targeted groups of individuals with developmental disabilities. The Family Supports Waiver will support individuals birth to 21 years. Please also note, under our Family Supports Waiver, that participants who are enrolled may remain on the waiver through the end of the school year that the individual turns 21 years old. The DDA's Community Supports Waiver will support individuals 18 years of age and older. And now our Community Pathways Waiver will support individuals 18 years of age or older in need of residential services. The applicant must have an assessed need for residential services unless the individual was enrolled in the waiver program, again, prior to that January 19th date. Next slide, please. If a participant is disenrolled from a waiver program, let's say, for instance, because the waiver participant temporarily does not meet applicable eligibility criteria, and then reapplies, they may be enrolled in a new DDA waiver program based on the following criteria. Individuals whose previous or current providers are authorized to provide services under the new waiver program, let's say the Community Supports Waiver, will be considered for a new waiver program, that meaning the Community Supports Waiver, based on established targeting criteria noted on the previous slide. Individuals who previous or current providers are not authorized to provide services under that new waiver program will be considered for their previous waiver program so that those services can continue with the existing providers. Next slide, please. Participants enrolled in the Community Supports Waiver with an assessed need for residential services may request to be enrolled in the Community Pathways Waiver. The Coordinator of Community Services would complete an initial person-centered plan on the Community Pathways Waiver and demonstrate the assessed residential service need. The DDA will assess the need and available slots for enrollment in the Community Pathways Waiver, such as our Emergency Community Supports Waiver participants with an increased need, and then take appropriate action. The DDA guidance to authorize funding in excess of the individual cost limit, or referred to another waiver, was updated to remove some of the information that's no longer relevant. The policy titled Refer a DDA Waiver Participant to Another Home and Community-Based Waiver Program is now live within the policy stat, accessible from the DDA home webpage. Next slide, please. Now we're going to talk about the LTSS Maryland waive placement. This specifically relates to our DDA staff and coordinators of community services. LTSS Maryland waives are the mechanism by which an individual who is currently on the DDA waiting list is authorized to apply for a DDA waiver program and enter services if they're found eligible for the waiver. DDA regional office eligibility staff place people on an LTSS Maryland waive as per the eligibility criteria set forth in each waiver program application. When placing a person on an LTSS waive, DDA eligibility staff select eligible DDA programs, such as our family supports, community supports, or community pathway waiver, for which the person may apply based on each waiver program's targeting eligibility and the available program slots. Once placed on a waive in LTSS, the system alerts the case manager, the CCS, to complete the DDA waiver application packet. Effective January 19th with our amendment, the following DDA program options apply. All children under the age of 18 shall have only the Family Supports Waiver program selected when placed on the LTSS waive. All individuals 18 to 21 without an assessed need for residential services could be placed on both the Family Supports and Community Supports program selection in the LTSS waive. All individuals 22 and older without an assessed need for residential services shall have the Community Supports program selected. And all individuals 18 to 21 and older with a potential assessed need for residential services should have the Community Pathways Waiver program selected. CCSs will work with the applicant to identify needs and create a person-centered plan applicable to the DDA Medicaid waiver program. Please note, in the event that the CCS identifies during the PCP development process a new potential assessed need for residential services, they shall inform the DDA regional office. The regional office can then add the Community Pathways waiver program option for the person so that can facilitate the application. Next slide, please. The individual cost cap for our Family Supports and Community Supports waiver has been removed and no longer applies. Therefore, the DDA's waiver service budget form that was previously used to estimate the annual cost of service is no longer applicable and therefore discontinued. This means CCSs no longer need to complete the form and include with the LTSS Maryland waiver application packet. We included a copy of the discontinued form in Appendix A of the guidance as a reference, which is also noted here on the left side. The DDA Regional Office Family Supports and Community Supports Waiver Individual Cost Limit Exception Form, which was used to recommend authorization for funding in excess of that cost cap, is also no longer applicable and therefore discontinued. We also include a copy of the form in the memo as Appendix B for a reference. Next slide, please.
Great. So you have about 10 questions here, but we're going to ask 3 because we have several slots to go through before today, and then we'll add whatever is we didn't get to in the master Q&A that you talked about at the beginning. So the first question is, are the community and family support waivers still limited to 400 slots each?
It's a great question. The family supports waiver remains limited to 400 slots, but the community supports waiver is not and has been expanded. Appendix B would show you the exact numbers.
Great. The next one is, what happens for people self-directing their waiver services if they are removed from a CPW? Can they be re-entered into it?
Individuals who are self-directing, regardless of the waiver, if they're found eligible, they can apply to re-enter into the waiver in the same waiver year that they exited.
Okay. The next one is, because of COVID, will participants for either the family supports waiver or the community supports waiver being extended beyond requirements?
I believe you're asking about possibly the cost caps or maybe the age. So the cost caps no longer apply. Individuals in the family supports waiver can continue to the end of their school year when they turn 21. We would be supporting them to transition into the community supports or community pathways waiver so that they could access the meaningful day services. So they would not remain if they no longer met the eligibility.
Okay. And then there's 3 more questions, and it has to be about what is the mechanism or what do you do to identify that somebody needs residential services, and how do you move from one waiver to the other?
Yeah, so for the assessed need for residential services, you would work with the coordinator of community services that would provide some information to the DDA to show the assessed need for residential services, such as maybe the person is now homeless and such. And in terms of the referral to another DDA waiver program, as I mentioned, if you go to the DDA homepage, you click on the policy stat link, that policy is now live and you can see the policy related to it.
Okay, and one more, Rhonda, and then we go to the next one. Is the individual cost cap for community supports waiver applies to new individuals?
The cost caps no longer apply. So there is no cost cap per person for either the family supports or the community supports waiver, regardless if they're in it or newly applying.
Great, thank you. I think you can go to the next slide.
Okay. Next slide, Donna. Thank you. Can you go? Okay, so this guidance, Memo 2, applies to applicants and participants, our CCSs, DDA providers, and regional office staff, and it relates to the development, approval, and authorization functions and processes for an applicant or participant's person-centered plan. This will apply to both self-directed and traditional service delivery models. Next slide, please. So one of the big changes that are impacting our person-centered plan relates to changing hourly service units to 15-minute units, day habilitation groups replacing our day habilitation small and large group, nursing support services replacing our 3 standalone services of nurse consultation, nurse health case management, and nurse case management delegation services, and that the community living retainer fee no longer displays in the detailed service authorization. Updates to LTSS Maryland's functionality related to the person-centered plan that I just talked about were released into the system on February 14th, and all new service changes will be effective March 1st. Information regarding these changes have also been shared via the DDA LTSS functionality update February 2021 and the LTSS February monthly spotlight and system maintenance notice. Next slide, please. To provide more flexibility for participants to design meaningful day services and to meet their needs and choices of activities and also mitigate that loss of potential revenue for providers, our 1-hour service units were converted and now will be reflected as 15-minute billing increments going forward. Updates were made to the PCP service authorization service calculation page that the CCSs uses to reflect these changes from hourly units to 15-minute units. CCSs can still facilitate planning with people and their chosen providers using hourly entries, and will also now be able to add additional 15, 30, or 45-minute units. It is recommended in our guidance to reflect the total units needed in terms of weekly units and select every day of the week to ensure that most flexibility is available and account for months with 5 weeks. It is also important to confirm with the DDA provider operational days as applicable when completing this section. DDA providers can note operational details in terms of the number of days in the Detailed Service Authorization tool to help communicate this information with the CCS and the participant. The LTSS Maryland system will automatically multiply out the hours entered and equate them into 15-minute units. This is a screenshot of the CCS view when entering service units into LTSS Maryland. Next slide, please. This slide shows the various services for which hourly units have been changed to 15-minute service units. You can see that it includes various meaningful day services, dedicated hours with residential services, and 3 of our support services. Next slide, please. All PCPs in the system that have an effective period that crosses March 1st was automatically updated to reflect another service line with 15-minute unit calculations. The system is going to track the new 15-minute service separate from the previous hourly services. This means the PCP will have 2 service lines, 1 service line with hourly unit calculations and 1 service line with 15-minute unit calculations, as shown in this screenshot. This is the CCS's view from the LTSS Maryland PCP Detailed Service Authorization section. Next slide, please. This is the provider view from the provider portal side. You will see that it also includes 2 service lines, 1 service line with the hourly unit calculations and 1 service line with the 15-minute unit calculations, as shown in the screenshot. Next slide, please. The guidance memo provides information related to action that may be needed based on the current status of the PCP. PCPs with effective dates on or after March 1st will only reflect the 15-minute units of services. PCPs that are in pending regional review status or approved status will not require any additional action by the CCS, provider, or regional office. The system will automatically reflect the new 15-minute service limit. Please note, the provider acceptance document will not match the 15-minute units. This is because the approved service by the provider was converted by a data patch to the 15-minute unit so that the service referral and acceptance process would not need to be completed again. The provider portal will reflect a system-generated acceptance with the following comment. It will state, this referral was auto-generated for a previously accepted service due to a system-wide update of billing units for this service effective March 1st. In progress and pending clarification PCPs may require DDA provider reacceptance if the provider has already accepted the hourly service so that they can now accept the 15-minute service lines. The CCSs should review the service authorization service acceptance and re-request exceptions as needed in accordance with the guidance. Next slide, please. Before discussing Amendment Number 3 changes related to day habilitation service, I wanted to first clarify a response to a question about day hab under Appendix K flexibility during the public health emergency. Please note that under the Appendix K authority, day habilitation services can be provided any day of the week as per our posted guidance. Once the Appendix K flexibilities end, DDA habilitation services can then only be provided Monday through Friday. We wanted to clarify this based on the questions we got from last week. So in terms of Amendment Number 3, effective March 1st, to provide more flexibility for persons to receive our day habilitation services, either in small or large groups, the Person-Centered Plan Detailed Service Authorization service option will no longer include a distinction between dehabilitation large groups or small groups, and will now reflect just dehabilitation groups as demonstrated on this chart. Pilot providers only billing through LTSS Maryland will bill for the specific DAHAB group, meaning small or large group, via the provider portal. As day habilitation services billed via PCIS2 are based on a daily unit, small and large group supports cannot be billed until that service transitions to LTSS Maryland. Next slide, please. All approved PCPs that have an effective period that crosses the March 1st will automatically update to reflect another service line for dehabilitation group unit calculations. This means that these PCPs may have multiple dehabilitation service lines, such as small group, large group, and dehabilitation groups, as shown in the screenshot. Please note, no action is required by the CCS, DDA provider, or the regional office for these approved PCPs. CCSs will see that for new, initial, revised, and annual PCPs in the service request options, that prior to March 1st, they will have all the options associated with dehabilitation, including small, large, 1-to-1, and 2-to-1 staff ratios, in addition to the groups. After March 1st, the service drop-down options will only reflect dehabilitation groups and dehabilitation 1-to-1 and dehabilitation 2-to-1 for their selections. This view again is the LTSS Maryland view from the PCP. Next slide, please. Here's an example screenshot of the provider view with the system auto-update changes to dehabilitation groups. Another service line was added with the updated service and the reflection of the updated billing unit for all months after March 1st. Again, please note that dehabilitation services are not fully live in LTSS Maryland. Only the pilot providers are currently billing this service in LTSS Maryland. All other providers must bill dehabilitation services via PCIS2. Next slide, please. This memo guidance also provides information related to actions that may be needed based on the current status of the PCP. PCPs that are in pending regional review or approved status, again, will not require any additional action. PCPs that are in progress or pending clarification status with the CCS may require DDA provider acceptance for the dehabilitation group service line. For dehabilitation groups, the PCP detailed service authorization for dehabilitation group service will reflect dehabilitation small group rates. Next slide, please. The CCS should note the following. When revising dehabilitation services within a PCP, dehabilitation small group and large group that end on or before February 28th cannot be edited. If the CCS attempts to revise these services, the system will display a message that this service cannot be provided after February 28th. When adding dehabilitation services, for adding dehabilitation services available only after March 1st, unit calculation months available are only after March, and previous months are grayed out. The system will display a message to reflect that the service is only effective March 1st of 2021. Next slide, please. CCSs should also note in the guidance that when adding a dehabilitation group provider, if a DDA provider has not been selected, the CCS can complete the provider search process to select the provider that the participant has chosen. If a DDA provider has already been noted, the dehabilitation groups through the DDA patch, the CCS will need to modify the existing service authorization as needed. If the CCS attempts to add another dehabilitation group line to the service authorization section, the following message will be displayed. it will state the selected provider number is already authorized for rehabilitation groups in this PCP. Please modify units on the existing authorization if needed. Next slide, please. In terms of our nursing support services, effective March 1st, the DDA PCP Detailed Service Authorization service option will no longer include nurse consultation, nurse health case management, and nurse case management and delegated services as a support service option, and will now reflect nursing support services as reflected in this graphic. Next slide, please. All approved PCPs that have an effective period that crosses March 1st will automatically update to reflect another service line with nursing support service unit calculations. This means that the PCP may have multiple nursing lines as shown in this screenshot. All approved PCPs will require no action by the CCS provider or regional office. Our new initial, revised, and annual PCP service request options, that drop-down options, prior to March 1st will include the legacy nursing services, and after March 1st, the only drop-down option will reflect nursing support services. Next slide, please. The guidance memo also provides information related to action that may be needed, again, based on the current status of that PCP. PCPs that are pending regional review or approved will require no additional action because the system will automatically reflect those units. PCPs that are in progress or pending clarification status with the CCS may require DDA provider acceptance for the nursing support service line. DDA providers may need to accept both service lines if applicable. The previous nursing services had different rates. Effective March 1st, the PCP Detailed Service Authorization section for nursing support services will reflect the current nursing case management and delegation service rate. Next slide, please. Similar to our rehabilitation services, when a CCSs revise a previous nursing service within a PCP that end on or before March 28th, they cannot be edited. If the CCS attempts to revise these services, the system will display the message, "This service cannot be provided after February 28th. When adding nursing services, as reflected in the graph on the right of your slide, unit calculated months available are only after March 1st, when this service option became available, and previous months are grayed out so that the system will display a message that says, "This service is effective March 1st. Next slide, please. CCSs should note in the guidance that when adding nursing support services, if a DDA provider has not been selected, that the CCS can complete the provider search process to select the provider that the person has chosen. If the provider has already been noted for nursing support services through that data patch, the CCS will need to modify the existing authorization as needed. If they attempt to add another nursing support service line in the service authorization section, they will get the message that states, "The selected provider number is already authorized for nursing support services. Please modify units on the existing authorization as needed." Next slide, please. And lastly, on this memo, effective March 1st, the PCP Detailed Service Authorization section will no longer display community living retainer fees as a separate line item. For PCPs effective before March 1st, community living retainer fees is currently auto-added to the community living group home service without requirements for acceptance. All approved PCPs that have an effective period that crosses March 1st will automatically update to remove the service line for subsequent months. The DDA PCP Detailed Service Authorization Service Icon Toolkit which is reflected with the arrow here on our screen as the I, will include a statement indicating how many retainer days are allowed for the services according to the current requirements, not including the Appendix K authority. The system will display the following message for these services. Authorization of this service includes residential retainer days as per DDA policy. For the provider view, providers will no longer see a retainer fee service tag along with the community living services that have been sent for acceptance. The provider will also be able to click on an icon toolkit to see that the retainer fee service is tagged along. Again, I want to emphasize this is not associated with the Appendix K retainer days. Next slide, please.
So folks have said this is a long section and they want you to stop talking so they can ask questions. So you got about 14 questions in this section. So I'm going to start from the beginning and end with nursing services, Rhonda. So the first question is when you were talking about the 15-minute increments and people wanted to know why was this funding amount different from the same services regardless of whether it is calculated by hour or 15 minutes, and is the CCS responsible to enter the 15-minute intervals in LTSS?
So good question. First, CCSs do not have to enter 15-minute unit increments. They can still do the entry into the service planning using hourly. They have the flexibility to also add 15-minute increments, but you can do it based on hourly units. And I didn't quite get the first question.
I guess it's why moving from an hourly rate to 15 minutes.
Yeah, and as we noted in the slide and also in our memo guidance, so please refer to the guidance memos because they have all this information. It's the same information to provide flexibility for participants in order to create their meaningful day. Currently, our services and our legacy system are based on a daily rate. And so when we went to an hourly rate, we heard from participants and providers that sometimes they don't want to use a whole hour of service. Maybe they only needed an hour and a half out of their day. And so by providing 15-minute increments, it provides more flexibility for the person and also supports the provider in terms of being able to bill for less than an hour under those circumstances.
Okay. The next one is still 15-minute increments. Will support brokers need to be calculating in 15-minute increments?
No, they could be calculated in hourly increments.
Thank you. Will providers will continue to use PCS2 for billing?
Yes, providers who are not associated with the pilot or the service has not transitioned, such as our personal supports or supported living, will continue to use PCIS2.
And people want to know, what is the pilot?
That's a good question. So the DDA, as per our transformation and transition into LTSS Maryland, has been working with a group of providers to pilot the system in terms of direct billing through the LTSS system.
Thank you. Where or how is it to be noted in someone has an assessed need for residential services? It is simply the CCS noted in the PCP?
Yes, the CCS would include information related to that assessed need for residential services in the PCP.
Okay, now moving to rehabilitation questions. Individuals that have rehabilitation provided for less than 5 days weekly, will they need to change to attending 5 days week now?
So participants have the choice and decide how many days they would like to receive services. Under the Appendix K authority, there's flexibility to be supported throughout the week. Under the waiver, once the public health emergency ends, rehabilitation services are available Monday through Friday only. Tricia, did we
Okay.
want to go through some of the other sections? I know we were going to try to do
I'm moving on. I'm doing day program right now, then I'm gonna do nursing, and then I'm gonna do authorization, and this is the biggest spot that you have, Rhonda, on the slot, so I'm gonna take as much time as I can, because the other ones is much smaller. So the next one is still in day. Can you bill day services for 7 days a week in PCIs 2 per Appendix K, and will PCIs 2 actually let you enter on Saturday and Sunday?
We'll have to confirm that with our fiscal and operations and provide that in our FAQs.
Okay, now I'm going to move to the nursing piece. There's still a lot of other questions on the service authorization. They want to know if the cost detail tool and the detailed service authorization tool would be updated to reflect the nursing support services.
Yes, it will be updated.
Okay. The other one is, will the new detailed service authorization be released to reflect the consolidation of day, groups, and nursing services?
The detailed service authorization in LTSS already reflects that. We will look at consolidating that in terms of the DSAT, the detailed service authorization tool.
Okay. Then somebody asked, what is a retainer fee?
A retainer fee is associated with our residential services that provides the ability for the provider to bill up to a specific amount of days when the person is not in the home receiving residential services, possibly because they're in the hospital, recovering, or visiting with family or friends.
When adding a new service for PCPs, will the system recognize that the new service added to the annual PCP?
Yes, when the CCS adds a new service in the LTSS, it will be reflected in the PCP.
Okay. All right. Somebody did this and it shows inactive. What does that mean when that happens?
If it shows that the person is inactive, then the person is no longer in our system noted as being an active participant. They should follow up with the regional office.
All right, thank you. You have about 3 more. Do you want to go to the next slide, or you want to continue asking a couple of questions in this section?
I think we should continue to move forward, and then we can circle back if you want to flag them.
I'm flagging them now. Go ahead.
Okay, next slide, Donna. Okay, go one more slide. So now we're going to talk about memo number 3. And again, I know this seems like a lot of information. This is information directly from our memo, so please know that you can refer back to them. Memo 3 relates to the option for participants to receive and our providers to offer virtual supports for the following services noted here: our employment services, supported employment services, community development services, day have services, and personal support services. Please note that virtual supports are an electronic method of service delivery. They are not a distinct, separate service under the DDA waiver program, but a means by which certain services listed above may be delivered to the person. You may recall under our Appendix K authority, some of our services can now be provided virtually during the state of emergency. Based on the stakeholder input, the DDA has incorporated this service delivery model option to continue after the public health emergency ends, provided specific standards and criteria are met. Next slide, please. The purpose of the virtual supports is to maintain or improve a person's abilities, enhance those interactions, support meaningful relationships, and promote the ability to live independently and meaningfully participate in their community. Virtual supports are geared towards intentional learning, such as career planning, taking a class, skill building, and can also be used towards helping a person do something more independently, like remote job coaching. Next slide, please. Direct supports can be provided via virtual supports, provided, however, that the virtual supports meets all of the following requirements. First, the virtual supports ensures the person's rights of privacy, dignity and respect, and freedom from coercion and restraint. The virtual supports do not isolate the person from the community or interacting with people without disabilities. The person has other opportunities for integration in the community via the other waiver program services that the person receives and are provided in community settings. Next slide, please. The use of the virtual supports to provide direct support has to be agreed to by the person and their team and outlined in the person-centered plan. Participants must have an informed choice between in-person and virtual supports. The virtual supports cannot be the only service provision for a person seeking the given service. The person must affirmly choose virtual support provisions over in-person supports, and the DDA provider should include in their provider implementation plan for this person, which should then be uploaded in the LTSS Maryland Person-Centered Plan documentation section. Next slide. Requirements also include that the virtual supports cannot be used for the DDA provider's convenience. They must be used to support a participant to reach their identified outcomes as noted in their person-centered plan. The virtual supports must be documented appropriately, just like any in-person direct supports, and identify the service delivery method. Examples are noted here on the screen, including the names of the staff person providing the service and the start and end time of the service. Next slide, please. The virtual supports must be delivered using a live, real-time audio-visual connection that allows the staff member to both see and hear the person. Please note, text messaging and emailing do not constitute virtual supports and therefore will not be considered a provision of direct support under the waiver program service. Next slide, please. The virtual supports must comply with all requirements associated with HIPAA and other health information technology as noted on the screen, applicable to regulations to protect the privacy and security of the person protected health information. The waiver program service for which the virtual supports is used may not be provided entirely via virtual supports. It may supplement in-person direct supports. Next slide, please. Don, I think we need to go back one slide. Thank you. Virtual supports, including the use of phones, cannot be used to assess a person for a medical emergency. Providers must develop and maintain written policies to address processes for preventing and responding to a medical emergency during the use of virtual supports. Train direct support staff on those policies and advise participants and their person-centered planning teams regarding those policies. You will see in the memo that at a minimum, provider policies must address identifying whether the person's needs, including health and safety, can be addressed safely, identifying individuals to intervene, such as uncompensated caregivers present in the person's home or others, and ensuring that they are present during provisions of virtual support in case of a participant's experience emergency, and processes for requesting interventions if the person experiences an emergency during the provision of these supports, including contacting 911 if necessary. As with all waiver service, virtual supports must comply with all federal, state requirements, policy, guidance, and regulations. Next slide, please. The DDA provider must develop, maintain, and enforce written policies approved by the DDA which address, 1, how the provider will ensure the participant's right of privacy, dignity, respect, and freedom from coercion and restraint, how the provider will ensure virtual supports used meet applicable information security standards we just talked about, and how the provider will ensure its provision of supports comply with the applicable laws governing the rights to privacy. Next slide, please. So a DDA provider may choose to provide virtual supports for some or all of the applicable services for which we have shared. DDA providers interested in furnishing these services via virtual supports must include virtual supports as a service delivery method in their provider program service plan as per their proposed business model. For each service, DDA providers shall specifically note the service delivery method, direct, in-person, and virtual supports as applicable, and include the scope and methodology in using these delivery methods. Next slide, please. Current providers must submit an amendment to their current program service plan to the DDA Regional Office Provider Relations Liaison and receive approval prior to implementing these virtual supports outside of the current Appendix K authority. Again, under Appendix K, we are providing virtual supports. You can continue to do that as per the Appendix K authority and do not have to do the program service plan. DDA providers that wish to provide virtual supports after the public health emergency will need to update their program service plan for the applicable services they propose to provide virtual support options, and that can be conducted as part of their annual relicensure or recertification process, or at least at a minimum prior to the end of the Appendix K authority. That means we have some time that we can work on these and get them into the regional offices and have them reviewed. Please note that the Appendix K flexibilities, such as providing services via virtual supports, will end 6 months after the end of the federal public health emergency. Based on federal communications that we have seen, it is expected that the public health emergency will be extended to the end of this calendar year. Therefore, providers' program service plan updates would need to be updated by June of 2022 unless there are changes in the federal public health emergency end date. Next slide, please. We also note in our guidance that the program will not fund any cost associated with this new service delivery model for obtaining, installing, or implementing the virtual supports. The cost in the delivery of this new business model are part of the provider's operating costs. And we noted some examples here, such as equipment, internet, software applications, and such, that they would be having on their side from the business model. Please note, participants with an assessed need for assistive technology can be requested within their person-centered plan to meet their individual assessed needs. Next slide, please. The memo also outlines some quality assurance related to virtual supports. Participants and their teams should assess the quality and the effectiveness of virtual supports to meet the person's assessed needs and preferences in accordance with the guidance. The coordinators of community services shall assess and document the quality and effectiveness of these virtual supports during their quarterly monitoring reviews, and more frequently as noted in the person-centered plan. If there is a desire by the person to change the way services are delivered, a revised PCP and provider implementation plan will be required. Health and safety concerns shall be reported to the DDA Regional Office Quality Enhancement staff. Next slide, please. The guidance also notes some information related to service limits, utilization, and audits. Please note the combination of virtual supports and direct support for a given service cannot exceed service authorized by the DDA within the person-centered plan. Virtual supports cannot be provided for 2 services at the same time. For example, personal supports and day habilitation. And the state has mechanisms in place to review for potential duplication of billing, including service utilization reviews and audits. Next slide, please.
All right, Rhonda, for this section, you've received 10 questions. The first one is where it says identifying individuals to intervene, such as uncompensated caregivers present in the person's home and ensuring they are present during the provision of virtual supports. In this case, participants experience an emergency. We have participants that live alone. If someone we support lives in a home and has no one to be with them during virtual supports, does this mean that they can now receive virtual supports?
The answer is no, they can still receive virtual supports. The guidance outlines some options and strategies for you to consider as a provider in terms of your policies and procedures for what you would do if you were providing virtual supports for a participant and they experience an emergency. Please note in the slides and in the guidance, we also use contacting 911 as an example. So you would want to look at all those options and outline that in your policy.
And just a couple of questions. People are getting confused between what is happening with Appendix K and what's happening after the Appendix K. So they're asking, is this information really about virtual supports of what will happen after the pandemic or now?
That's a great question. And the answer is the information we're sharing today is after the pandemic. This relates to Amendment number 3. And we included virtual supports as a service delivery model so that when Appendix K ends, that our providers and participants who have told us that they would like to continue this option in the future can continue to receive virtual supports based on their choice and meeting these requirements we've noted as we move forward in years and time after the pandemic has ended.
Okay. I'm going to do one more so we can move on, and then we have time at the end, I'll come back to them. But regarding virtual support, what is the minimum face-to-face time required for it to be the only provision? We have a person who, anyway, what is the minimum time required?
That's a great question. We'll take that back and look at that so that we can make sure that we specify that in our guidance.
All right, Ron, I'm going to just hold on and you can go into the next one, and we have time, we'll come back to this memo.
Great. Thank you, Patricia. Next slide, Donna, please. Okay, let's go one more slide. So Memo 4 relates to the provision of supports during an acute care hospital stay. Direct support services, meaning personal, behavioral, and communication supports, can be provided in an acute care hospital setting under the following services: our CDS, our day habilitation services, personal supports, community living services, and supported living. It is important to note that support services cannot duplicate services the hospital is required to provide to its patients. These support services may not interfere with necessary treatments to the person rendered by the hospital. You may recall, under DDA's current Appendix K authority, some of our services can be provided in an acute care hospital setting. Again, based on the stakeholder input, the DDA incorporated this service delivery model option to support persons when they are in the hospital after the public health emergency ends, provided specific standards and criteria are met as outlined in the memo and waiver application. Next slide, please. Personal, behavioral, and communication supports needed for the person otherwise provided in the hospital must be identified in the person-centered plan, such as noted in the provider implementation plan, nursing care plan, or behavior plan. They must be provided to meet the person's needs and are not otherwise covered by the hospital. They should not substitute for services that the hospital is obligated to provide to its patients by laws and regulations, and should be designed to ensure a smooth transition between the hospital setting and the home and community-based setting. Next slide, please. DDA providers interested in furnishing this service after the public health emergency ends for people who are in and receiving acute care hospital must include this service delivery method in their provider program service plan for each service that they propose to have this as a business model. Current DDA providers will need to submit an amendment to their current program service plan to the DDA regional office provider relations liaison and receive approval prior to providing these services after Appendix K ends. They can complete that update to their program service plan, again, during their annual relicensure or recertification process, but it must be completed prior to the end of the Appendix K authority so that they can continue to provide that after it ends. Next slide, please. DDA providers, you must document in the person's record the provision of these supports during a person's stay in an acute care hospital setting. This would include service notes describing service activities as authorized by the PCP, a description of the service provided, including the dates of service, service provided, time of service, location, and name of the staff person that provided the service. Please refer to this guidance, which includes an example of a service note, which is similar to the requirements that we have currently under the Appendix K authority. DDA providers, you should maintain copies of staff timesheets that documents the presence of the staff who provided the service under the time billed, and provide documentation upon request by the department. Next slide, please. We also note in our guidance quality assurance strategies to include the CCS shall assess and document the quality and effectiveness of supports provided in the hospital setting during the follow-up on status and discharge planning. Health and safety concerns should be reported to the DDA regional office quality enhancement staff. Next slide, please. And similar to the other service provision, the total combination of supports provided during an acute care stay or in the community cannot exceed the services authorized by the DDA within the person-centered plan. Only one DDA waiver program service can be provided and billed for at a specific time. Therefore, if a person is receiving personal supports and CDS services, only one of those can be providing the supports in the hospital at a time. The state has mechanisms in place to look for duplication of billing to include those service utilization reviews and audits. Next slide, please.
All right, Rhonda, for this one, can you identify what you mean about acute care hospital setting?
Yes, so what we're saying is if someone has an illness that requires them to stay in the hospital for an acute care stay, for a short-term stay, that's what we're referring to.
Okay, the next one is, how would personal supports provide, especially for family members, to know what is being charged for day program? For example, my child engages in the morning coffee hour for Zoom with her meaningful day program, but I also provide personal supports for her during the day, including when she's on Zoom. What is the best way to navigate this and not duplicate billing?
Yeah, I think that relates to our virtual support services. And so you need to ensure that if personal supports is being provided, that is the only service that's provided. If the person receives day habilitation services, then the day habilitation services would be provided and not personal supports.
Okay, and then the last one was for acute care hospital support. Wouldn't this be tougher to coordinate a meeting while someone is already in the hospital so we can update the PCP or the PIP?
That's a good question. Please note, under the Appendix K public health emergency, we do have provisions where these supports can currently be provided now. Going forward, after the public health emergency, and you can do this now today, you can coordinate with the CCS to include information in the person-centered plan, coordinating with the provider in terms of what supports they're providing to.
Let's move to personal supports memo.
Great. Next slide, please. Let's go one more slide, Donna. So Memo 5 relates to the provision of personal supports, authorization of 2-to-1 staff to participant supports based on the person's assessed need and the implementation of transportation service components. As you may know, personal supports is a 1-to-1 staff to participant support and also includes the option for an enhanced rate to support people with an approved behavior plan or health risk screening tool score of 4 or more. The waiver amendment includes, it is adding the ability for the DDA to authorize 2-to-1 supports. As part of the required transition to LTSS Maryland, personal supports now includes transportation as a cost component within the established rate. Therefore, a person cannot be authorized to receive standalone transportation services at the same time as personal supports. As per our approved waiver programs, our personal supports includes the provision of direct support services, transportation supports, our delegated nursing task, and also personal care assistance based on the person's needs, but cannot comprise the entirety of the service. Next slide, please. Donna, next slide, please. 2-to-1 staffing supports must be documented in the PCP risk section as one of the mitigation efforts in addressing applicable behavior or medical risk. As 2-to-1 staffing supports can be limiting and restricting of a person's rights, the service must include a fading plan, must include justification for increased staffing, and associated information must be documented within the person-centered plan and either the nursing care plan or the behavior plan as applicable, including information related to the following: the needs and risks that are being addressed, when the 2-to-1 supports are specifically needed, descriptions of any other applicable resources, such as natural, community, school supports, community first choice, other Medicaid state plan services being explored and exhausted by the team to meet that person's behavior medical risk needs prior to requesting authorization of 2-to-1 supports. The guidance memo also includes additional information needed, such as why resources cannot meet needs, natural resources in place, assessment of assistive technology, adaptive equipment, and other environmental modification alternatives, and information related to that fading plan. Next slide, please. When adaptive equipment, assistive technology, or other environmental mods can address the need, the DDA may authorize temporary 2-to-1 staffing supports while these items are put into place. If the DDA does temporarily authorize 2-to-1 staffing supports and the technology, equipment, or environmental modifications, we expect that those to be put in place within 90 calendar days of the initial request. If the technology, the equipment, and modifications provided are later determined to not be able to mitigate the need for the 2-to-1 staffing supports, then a revised PCP can be reviewed by the DDA to determine if the 2-to-1 should continue and if the appropriate level of service is noted. So we can go back and authorize those staffing supports if those strategies do not meet the needs. Next slide, please. If the DDA authorized 2-to-1 staffing supports, they will be approved for an initial period of 3 months. During this initial approval time and any subsequent approval, the participant's person-centered team shall implement the fading plan and assess the effectiveness of the service and options. If needed, a CCS and team can submit a revised PCP based on the person's assessed need to extend the time of the support and update the fading plan. Please note, after the initial approval, 2-to-1 staffing supports can then be approved for additional months up to an annual approval based on the assessed need and extenuating circumstances. Next slide, please. This slide relates to the transportation component. The rate for personal supports includes transportation services as a component of the service. Therefore, as we've mentioned, participants enrolled in either the traditional model or self-directed service delivery model may not request authorization and bill for standalone transportation services to be used at the same time as personal supports. Participants using the self-directed service delivery model should work with their CCSs to revise their person-centered plan and self-directed service budget sheet as per the DDA memo, self-directed service person-centered plan process, and rate increase memo dated December 31st. Next slide, please. Similar to other services, the state has mechanisms where we could look to ensure prevention of duplication of billing, such as our service utilization and audits. Next slide, please.
Hi, Rhonda. Is transportation using public transportation approved for personal supports?
Yes.
Personal supports can now include ADL care as long as it is not the whole plan. Is that correct?
Yes, and that has been the case for some time.
Is nursing stand-alone services in personal supports?
Personal supports does not include nursing as a service component.
So if somebody needs nursing,
they would request that as a, they would request the new nursing support service standalone service.
Okay. And this last one before we move to the next one is when somebody doesn't have standalone transportation under personal supports, can an individual that does not have transportation to get to and from places, how would they need to do a standalone service if they got transportation, or you're saying that it's included in personal supports?
We are saying it is included as a component of personal supports.
Okay, let's move to the next memo.
Great. Donna, if you can go to the next slide, and then one more. So our memo number 6 relates to the provision of support to more than one person under our community living group home services and supported living services based on the person's assessed need and specific criteria being met. Next slide, please. For these services, our community living and supported living services, the level of support and meaningful activities provided to the person under the waiver program must be based on the participant's level of service need. Please note that 2-to-1 and 1-to-1 staff to participant ratios, referred to as dedicated hours, may be authorized for participants. 1-to-1 and 2-to-1 dedicated supports authorized for a person due to medical or behavioral needs cannot be shared with other participants residing in the same residential setting. Next slide, please. The DDA may authorize dedicated supports to be used to support more than one person in that residential setting if it meets each of their assessed needs and the following circumstances are met. 1, the participants are retired, transitioning from one meaningful day service to another, recovering from a health condition, or receives less than 40 hours of meaningful day services per week. The dedicated support hours are documented in the participant's respective person-centered plan and the provider implementation plan. And the DDA provider may only bill the dedicated support hours for one participant to avoid duplication. Again, as noted on our previous slide, 1-to-1 and 2-to-1 dedicated supports authorized for a person due to medical or behavioral needs cannot be shared with other persons residing in the same residential setting. Next slide, please. Providers interested in providing dedicated supports to more than one person should include this service delivery model in their program service plan. Current providers must submit an amendment to their program service plan to the DDA Regional Office Provider Relations Liaison and receive approval before implementing the service model. Next slide, please. As per the guidance memos, the DDA provider must establish and enforce written policies under this model to ensure that each person's assessed needs are being met, that the participants' rights of privacy, dignity, and respect, and freedom from coercion and restraint, that shared supports have been agreed to by the participant and their team and is outlined in the person-centered plan, that these shared supports must be documented appropriately for each person, including the name of the staff person providing the service and the start and end times, and include processes for accounting and tracking the billing dedicated support hours for the person. Next slide, please. As we mentioned before, we do have systems put in place for service utilization and audit so that we can review and prevent duplication of billing. Next slide, please.
Okay, for this one, you have about 8 questions, so I'm going to read 3 of them. We are having problems getting our CCSs to request the full dedicated hours needed for some of our participants. Those that are currently that have a 5 on the matrix score for supervision have 58 hours of one-on-one embedded in the matrix. These individuals need one-on-one support, but the CCS only wants to request 24 dedicated hours leaving or one-on-one unfunded. Well, do you want to talk about that a little bit, Rhonda? Because I think people are comparing apples to oranges. So we want to just make sure how we are looking at people's dedicated hours and what does the matrix really mean and does it mean as we move forward. So that's why I read the whole scenario so we can make sure you know where I was coming from with this question.
Sure, absolutely. So again, please note on the DDA website under our transformation and LTSS pages and our person-centered plan pages, we have information about working into our 2 different systems, meaning PCIS2 and LTSS. And so based on the system you're in, it's going to reflect different information and different billing options. Per our person-centered plan development and authorization guidance, we have added additional information in there related to dedicated hours. It includes the differences in terms of looking at overnight supports that would be available in the home, whether dedicated supports are being provided, and looking at the shared hours. And so again, I strongly encourage you to look at the person-centered plan dedicated DDA page that includes the PCP development and authorization guidance that will provide you with additional information related to dedicated supports. If you need assistance, as we've noted at the beginning, our regional offices are available to help facilitate in conversations with you and the CCSs to ensure understanding related to the information and operating in the 2 different systems.
Okay, the next question, thank you, Rhonda. The next question is, can we be approved for dedicated hours for awake overnight staffing if needed for someone in community living group home services where overnight supervision is already provided?
Yes.
Great. And then I'm gonna do one more and we can move on. So does this mean that shared services funding would be in both individual service authorization? If two individuals are sharing 10 hours per week, would it be funded for 5 hours for each person or for both for 10 hours a week?
That's a great question, and we would want to see that in the provider implementation plan and in the person-centered plan that would reflect the individuals that we're going to be receiving those shared hours and how it would be noted within the system so that we don't duplicate the billing of those service units. Patricia, you want me to finish up the last few slides?
Yes, go ahead, and because as you're talking, 4 different questions came up, and we'll come back to this ones for sure before we end.
Okay, great. So just a couple more. The next slides are little less dense. So for our memo number 7, this relates to nursing support services. And since we've consolidated those 3 nursing service models that we talked about earlier into that single nursing service called nursing support services, Memo 7 relates to and provides information to let the providers know that they should update their program service plan to reflect the changes to nursing support services. Next slide, please. And so the current DDA providers can do this update during their annual recertification process. They would work with the regional office provider relations liaison. And we would like to have this worked on and updated prior to the end of the current fiscal year. Next slide, please. Donna, let's just go ahead and go to the next one for Memo 8. Yep. And so for Memo 8, this is specific to our coordination of community services, changing from a licensed service to a DDA certification service. And so as noted here and in our guidance, we're alerting our CCS agencies that during their next annual reapplication process, that the current providers would complete the process for DDA recertification. It will not go through the licensure process with the Office of Healthcare Quality. Next slide, Donna. And that brings us to the end. And as Patricia pulls up a few more questions, just a reminder that the information I shared today is all from the 8 program-specific memos posted on that dedicated webpage that you can refer back to.
So Donna, why don't we go back to the second slide and leave it up so people can see, and I'm going to read what's been popping in the chat. And this one, it goes back to Memo 6. When providing dedicated hours to one person in a 3-person home, for example, you may have to unforesee an emergency when, for example, the one-on-one staff gets sick, has to leave, etc. And then the other staff must cover the third individual until the agency gets other supports there. In this case, we have usually put in the PCP that the hours on rare occasion are shared time limited in an emergency situation. Is this permitted for an emergency when you have no other choice?
What I can tell you is we request approval from the federal government to be able to have dedicated hours to support more than one participant. And as we outlined in our memo number 6, really we were looking at supporting individuals who during the day may need some supports, and so that shared staff could be there if the person, maybe one of the person's retired, one person's transitioning from a meaningful day service to another and hasn't started it, maybe someone's home recovering from a health condition, and such. And so we had requested the specific approval from CMS to do that and to bill under those dedicated hours. As I mentioned, if a person has dedicated hours for 1-to-1 or 2-to-1, as noted and required in a nursing care plan or a behavior plan, that those hours cannot be used as shared hours.
The next one is if a home is categorized as having awake overnight staff in LTSS and additional dedicated hours are requested for an additional person, would that indicate that the provider is requesting funding for 2 staff to be in the home overnight, 1 for general staffing, and the second staff to provide the dedicated hours?
Yes.
Okay. Where can we find additional guidance on what nursing supports are already, including, in other words, like for rehabilitation services?
That's a great question. So within the waiver program applications, the amendment number 3 that we have on the dedicated web page, you will see under each specific service the components of the service, such as the direct provision of direct support hours, whether transportation is included, and also nursing supports. Please note that for all our meaningful day services and our residential services, meaning community living services, shared living, and our supported living, all include nursing support services.
Rhonda, can you clarify a little bit about, so we have one that says you barely touch on anything dealing with changes to supported employment. Maybe I'm mistaken, but that's okay. When can we expect another major update? I believe the last major review of those was back in October. So can you talk a bit about what's in our Amendment 3 and what we said about employment services and moving forward?
Sure, absolutely. So as we have had in our waiver programs from the renewal from 2018, noted in Amendment number 1, number 2, and still reflected in Amendment number 3, is the DDA is transitioning from our legacy employment services, meaning supported employment and employment discovery and customization, to our new service called employment services. And so we've reflected in our amendments that due to the delay of the full transition into LTSS, where our new employment services would apply, we will continue to offer those legacy services that can only be billed through PCIS2. As noted in Amendment number 3, you'll note in some of the slides in our guidance that supported employment services can be provided via virtual supports. So we've mentioned them there, but please note that these services will be transitioning out once the full transition into LTSS occurs.
Thanks, Rhonda. So just as things popped in, I think people are still getting confused on the adding hours. Many providers are asking for dedicated hours to be added for supports that is based on awake overnight or was in PCIS2 or matrix. And I think they're getting confused and they're trying to equate a matrix to dedicated hours. And I saw 5 of those popped in after you answer the question. So I don't know if we need to provide additional clarification. I don't think people really are clear on the overnight supervision in community living group homes. That means that staff can be asleep in the home. Do you want to talk about it? I think people are getting, I feel like we may just need to do a webinar just on dedicated hours and overnight staff awake and asleep and those kinds of things. But do you have any guidance, Rhonda, you can give the group, because it's already 2:30 and I want to be respectful of people's time.
Yeah, those are really good questions, and we recognize that it may be a bit confusing for some people. Please note that we are transitioning out away from the matrix in terms of those hours and associated there. As I mentioned, the DDA has issued guidance about the transition of services and operating in 2 systems. So what does a dedicated hour in LTSS mean, and how would that be looked at and authorized within PCIS2? This information is available on our website. I believe we posted it initially back in September. What we're talking about today in terms of dedicated hours to support more than one person, we're really talking about hours during the day. We're not talking about night hours, awake overnight hours. We're talking about during the day when a person, when a couple people may be not engaged in community activities. They're retired, recovering from a health situation. They're in the midst of transitioning from one meaningful day service to another. And they don't have a behavior plan or a nursing care plan that requires a one-to-one or two-to-one support, that under the amendment, it provides the flexibility. So a provider can have one staff that can support more than one person in the home. They could share those supports based on the criteria we talked about. If you're confused about awake overnight or dedicated hours for residential during the nightly time, please refer to the DDA Person-Centered Plan Development and Authorization Guidance. Please also refer to the DDA guidance for service authorization and provider billing. We've included additional information in there, including the update to the shared hours noted for LTSS. If you need additional assistance, again, please reach out to the regional office that is available to help and assist you.
Thank you, Rhonda. I do want to let everybody know, as we get these questions, we really try to look to see how many that were received, that we may want to go back and do a specific training or specific guidance just specific to a topic. But very open to hearing your feedback. I know there was memos we went over in an hour and a half with lots of slides, but it was really pulling out the critical information from the memos. The memos have a lot of specific detail. If you think that in those memos we need to provide additional clarification, or there's statement of an unintended consequence that we may not consider, we are open to hearing your feedback. And so I would ask to send them directly to myself or Rhonda Workman, so that we can bring it to the management team at DDA to look into it and address it and then move forward. So with that being said, I would like to thank all of you guys for helping us in moving this hurdle across. And now we are in the implementation of our Amendment 3. And we will follow up with some of the operations in reference to the detailed service authorization and updates as of March 1st. So thank you and have a wonderful weekend.